Okay, so how do we treat T-cell lymphoma? Well, to me, treatment have three goals. First goals is get the disease under control. People don't feel well when they have T-cell lymphoma, so the first couple rounds of therapy is always to make them feel better. And then the second goal is really to aim for a long-term remission. Um, and the common therapy for peripheral T-cell lymphoma, the first line is usually combination chemotherapy. So you probably hear CHOP, which is a little bit more extensive. In certain patients, we use dose-adjusted EPOCH, or sometimes we add a drug called brentuximab into it if patient is CD30 positive or they have anaplastic large cell lymphoma, which is a subtype. Remember, the subtype tell us what treatment we get. And sometimes we even use additional target therapy for those patients. And based on the subtype, we're going to determine, based on the subtype and the response after you complete the first course of the treatment, we will determine whether or not transplant is needed. And then if we're going to go to the transplant, what type of transplant we do. And then I just listed some common neurotargeted agent that really has pushed the field forward and make my patients survive longer. So that includes your brentuximab, which is a CD30 targeting drug, and then a lot of epigenetic modifier like belinostat, romidapsin, and then duvelisib and azacitidine. And pralatrexate. So those are the newer drugs that we use for relapse disease. And again, I cannot, if you have ability to be part of the clinical trial, I will highly recommend it. It's important for new therapy, and it's important because the prognosis or outcome of the peripheral T-cell lymphoma is still not good. So trial might be the only option when we move that bar a little bit higher. So this is a better visual presentation of how we treat those patients. And this I borrowed from NCCN guideline. They have a very nice patient education material. So first-line therapy, I usually restage after 2 to 3 cycles. And then if they have good response, I continue to finish. If they don't have a good response, then we start second-line therapy. And then after this, finish first line therapy, and they have a complete response. That's when you talk about, the transplant and what type of transplant. And then for second line therapy, usually for relapse refractory peripheral T-cell lymphoma, we are not able to cure in the second line setting. So a lot of times, a patient, in order to get cure, right? Cure means not something like in the great talk earlier about if multiple myeloma can be cured. The cure here means that you're free of disease without needing any treatment. A lot of patients can still, even though they're not cured, they can still achieve this functional remission stage, functional cure stage where they're on a very reasonable, tolerable therapy. But they have to be on the therapy continuously in order to stop disease from coming back. And then I tend to use a lot of more newer agents, those novel agents that we talk about instead of chemotherapy on the second line setting. I think chemotherapy is a great choice if you can go to the transplant right away. But if you cannot go to the transplant, chemotherapy kind of control the disease only very briefly, and then the disease eventually relapse.